gastric bypass and the Billroth II. I'd like to start off by congratulating Dr. Carvalho on an excellent plan for our upcoming Congress. It's going to be held in Valladolid in 28, 29 of June, so I hope everyone will come. Here's the website if you're interested. There's a 17-page program for the upcoming meeting. It looks very exciting, so we certainly encourage all of you to attend and congratulate Dr. Carvalho on creating such a wonderful conference. We look forward to seeing all of you there. Okay, we're going to talk about the mini gastric bypass, but we're going to introduce it by saying we want to explain something as far as this confusion about the Billroth II, which is a primary component of the mini gastric bypass. And what we're going to say is that it's worth understanding it because the MGB is so very good. And what we mean by that is the MGB has a lot of advantages. Most importantly, it can be tailored to fit the patient and the surgeon. There are very high levels of patient satisfaction in both general surgery data and controlled trials and bariatric data. The MGB is up to twice as effective as the sleeve for the treatment of diabetes. Resolution rates have been reported as high as 85 to 90%. It decreases hunger, cholesterol, blood pressure, and inflammatory measures. It enforces a healthy Mediterranean-type diet. And very importantly, in contrast to the sleeve, for example, it's easily reversible and revisable, and it has that advantage over the Roux-en-Y as well. This unique advantage of the MGB is its ability to be tailored. It doesn't have to be the same operation for each patient, and that's exactly opposite of the sleeve, the Roux-en-Y, and the vast majority of other operations. Basically, it's good for the usual bariatric patient. As we said, it's ideal for the diabetic patient, probably the best choice. It's good for the super obese patient because you can make it more powerful. It's confusing, but a lot of surgeons don't understand this, but it's really good for patients with acid reflux. It's very good for the difficult patient because it's reversible in less than 60 minutes. So if you choose someone who has psychiatric illness or risk of alcoholism, the MGB can be tried, and if it doesn't work for the patient or there are other issues, it can be essentially removed in a matter of a few minutes. It's good for severely ill patients or those with liver disease because it can be staged and created as a very mild version of the MGB and then come back and added to the power of the operation with a second stage. And most bariatric surgeons I talk to don't understand that topic at all. It's good for borderline patients, the frail and elderly and young unmarried female because again it has this reversibility factor. A psychiatric patient who turns out is not a good match for the operation, it can be undone. A young unmarried female, even a child, can have an MGB because at any time it's easily revisable or reversible. But maybe most importantly, the MGB can be done with zero weight loss, and in those cases it's an excellent treatment with its duodenal exclusion. It's an excellent treatment for diabetes. This particular presentation is kind of to talk about the Billroth II connection. But first, let's compare it. Let's compare the MGB to the sleeve. Sleeve is popular, but the sleeve is not as good as the MGB. In all the controlled prospective trials, in all the meta-analysis and systematic analysis, the MGB outperforms the sleeve. So let's look at some of these. But basically, here's a study of 17 published studies, almost 7,000 patients, and they concluded that the MGB is better, had better weight loss, better revision and remission of comorbidities like diabetes and high blood pressure, high cholesterol, etc. The MGB patients had a shorter hospital stay and a lower death rate. And so let's emphasize that. The sleeve is associated with one of the most tragic, difficult, and deadly leaks in all of gastrointestinal surgery, and that's a leak near the EG junction. It can often result in months and months of hospitalization and even death. And the MGB, when following standard protocols by competent and skilled surgeons, leaks can be managed in a straightforward and easy manner. The sleeve also had a much higher rate of acid reflux, and we know that that's associated with increased risk of Barrett's disease and ultimately an increased risk of esophageal cancer. In a study by Dr. Wang, comparison of safety and effectiveness between MGB and sleeve gastrectomy, another recently published meta-analysis and systematic review, again, due to the safe and simple process of and effective outcomes. Laparoscopic MGB has become one of the most popular procedures in some countries. And in particular, they found that a systematic literature search was performed. The MGB had higher 1-year weight loss, higher 5-year weight loss, lower leak rate, higher resolution of diabetes and sleep apnea, lower overall rate of complications, lower gastroesophageal reflux, shorter hospital stay, and importantly, lower revision rates, because you're seeing revision rates of failed sleeves and lap bands of up to 30+% now. So basically, in all of these measures, the MGB is better, but in this study also, a comparison of revision for failed sleeves and failed lap bands. In this comparison, MGB was compared to Roux-en-Y, and the MGB noticed that it was significantly a shorter operation, an easier operation, a simpler procedure with better weight loss than the Roux-en-Y. So we can look at all of these and now come back to a concern raised by what we would call relatively uninformed or misinformed or confused other bariatric surgeons who stumble upon the fact that the MGB is just general surgery. They get wound up over the fact that the MGB uses a Billroth II connection. And so we want to talk a little bit about that and kind of demonstrate that when people raise concerns about the Billroth II, they're basically forgetting some of the basic principles of general surgery. What we want to point out is that the mini gastric bypass is just routine general surgery. It's an equivalent of a partial gastrectomy and a Billroth II gastrojejunectomy. And when it was first performed by me in 1997, we thought that was a rather long and complex name, and it was done laparoscopically, one of the few laparoscopic gastric bypasses done in the world, so it was called a minimally invasive or a mini gastric bypass. We want to begin by telling you that general surgeons, trauma surgeons, cancer surgeons routinely use the Billroth II every day all around the world. So that when bariatric surgeons get confused and start raising fears about the Billroth II, they're misunderstanding a basic principle of general surgery. So we'll show you some examples, and I could do hundreds of these, but I'll just pick out a few. I'm going to choose them from China, Korea, and Taiwan, Japan, other areas that are known to have very high risk of gastric cancer. And I chose that because one of the confusing things that some bariatric surgeons raise, they say, ooh, Billroth II is associated with increased risk of gastric cancer. Well, we want to point out that more knowledgeable surgeons than they, gastric cancer surgeon specialists, routinely use the Billroth II in some of the areas that have the highest risk of gastric cancer in the world. So you have an inexperienced bariatric surgeon raising concerns, whereas oncologic surgeons, cancer surgeons, routinely use the Billroth II. We'll leave you to decide who's more educated and more knowledgeable about the concerns of the Billroth II. So here's a study we'll start off with in 2016. This is from Korea, a high-risk area of gastric cancer. They took people that had already developed gastric cancer, who were having surgery for gastric cancer, and they did a distal gastrectomy. They took away the bottom part of the stomach, and 40 patients had a Billroth II and 9 had a Roux-en-Y. In other words, Billroth II chosen most commonly by these gastric cancer surgeons. Not to say Roux-en-Y is bad, but their number one choice is the Billroth II. Here's another study, 2017, also from Korea. They looked at the outcomes of patients with gastric cancer. A lot of these patients had a Billroth I, 20% had Billroth II, and 10% had Roux-en-Y. Again, not to criticize Roux-en-Y, but gastric cancer patients treated by oncologic surgeons in Korea, Billroth II was chosen 2-to-1. Here's a study from Taiwan, quote, the subtotal gastrectomy accompanied by vagotomy is the primary reconstruction of the Billroth II after distal gastric cancer surgery. In other words, the primary standard of care around the world for removal of the bottom part of the stomach for a small gastric cancer is a Billroth II, 2016. Hello, it's the standard of care. Here's a study from Japan, another area of a high risk of gastric cancer in 2017, just this past year. Again, Billroth II was chosen, Billroth I was chosen in a third, Billroth II in just about 2/3, and Roux-en-Y in only 3 cases or 1%. So in Japan, the number one choice for reconstruction after a cancer surgery was not a Roux-en-Y, but it was a Billroth II by cancer surgeons in high-risk cancer area of Japan. Billroth II is the number one choice. Why? Because it's a standard of care. Here's a study of 1,000 plus patients from China, again a high-risk area. Between 2008 and 2015, 785 patients had Billroth II. 150 roughly had total gastrectomy and Roux-en-Y, but no Roux-en-Y was ever done for a partial gastrectomy. Never, 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 never. Nothing wrong with the Roux-en-Y, but they never chose it if they were doing a distal partial removal of the stomach. Always, in this study, always, they chose a Billroth II. Roughly 3/4 Billroth II. The other 1/4 Billroth I, never a Roux-en-Y. Doesn't mean a Roux-en-Y is bad, it just means that gastric cancer patients routinely receive Billroth II operation all around the world. Okay, here's another study from China, and this is about diabetes, basically showing that when a standard thin patient has gastric cancer surgery, both Billroth II and Roux-en-Y help control the blood sugar of the patient. But the most important point is in this article, there's never a worry, a concern, or a problem raised about Billroth II versus Roux-en-Y. They just simply stated some patients had Billroth II, some had Roux-en-Y. The Billroth II, in short, is a good procedure when done right. Why bariatric surgeons are confused is because of the old Mason loop gastric bypass. This was a bad operation, not because Billroth II is bad. It's bad because the MGB type connection was not used. The Billroth II connection was misused by Mason. It placed the gastrojejunostomy connection near the esophagus. That violates general surgery. And unfortunately, confused bariatric surgeons have forgotten this basic principle. Now, because of this widespread confusion, you often hear confusing misstatements by bariatric surgeons, denigrating the Billroth II and sometimes the mini gastric bypass. I'm frightened of it, beware of it, everybody needs endoscopy, there's bioreflux. All of these are confused because they misunderstand the basic experience of more than 100 years of general surgery. So let's go over this. First, we're going to point out that the Billroth II in and of itself is a good, safe operation, and those people who undergo Billroth II are made healthier. While some bariatric surgeons fear the Billroth II, general surgeons are routinely using the Billroth II all around the world. What we're going to say is that Billroth II is a good, safe operation that actually makes people healthier. We're going to show in the next couple of slides that the Billroth II decreases the risk of stroke, heart disease, and diabetes and more. That is, those patients who have a Billroth II are made healthier by the operation. So here's the first example. This is almost 6,000 patients, and this is from the country of Taiwan, and they have a nationwide healthcare database. Everyone who gets healthcare goes into the database, so they know about every patient who had ulcer disease in the entire country. And what they found is there were about 6,500 people who had Billroth II for severe ulcer disease. In other words, they had the worst form of ulcer disease, either bleeding or blockage or persistent pain or something that led them to have surgery. And they had a Billroth II, a standard form of general surgery. Let me say it again. Hello to confused bariatric surgeons. 6,500 patients in Taiwan had the Billroth II for ulcer disease, not Roux-en-Y. Why? Because Billroth II is not a bad surgery. It's a standard of care. And they know about every one of these patients because in Taiwan, everybody goes into their national healthcare database. And they also know about the other patients who had ulcer disease but didn't have the Billroth II. So they had an opportunity to compare the outcomes. They matched for age, date of birth, for the size of the patient's weight, and other medical illnesses, and they compared the outcomes. They asked this question: the Billroth II patients with severe ulcers versus the patients without operation but ulcers. The Billroth II patients did better. They had a lower risk of stroke. The Billroth II made them better. In a similar study published in 2017 in obesity surgery, the Billroth II patients who had Billroth II surgery for ulcer disease had fewer heart attacks. The Billroth II patients who had Billroth II for ulcer, otherwise the same, had fewer episodes of coronary heart disease. The Billroth II protected patients from heart disease. The Billroth II is good. Finally, in another article published in 2016, again from the National Health Insurance Database, matched patients who did not receive a Billroth II had more than 50% higher risk of diabetes. The Billroth II by itself protected against diabetes. The Billroth II in thousands of general surgery patients compared to the same kinds of patients without a Billroth II showed that the Billroth II decreased the risk of stroke, heart disease, and diabetes. In all countries around the world, general surgeons routinely use the MGB type connection, the Billroth II. Only confused bariatric surgeons who misunderstand basic general surgery continue to raise fears about the Billroth II. I'll go ahead and stop there, and thank you all for watching, and I hope that this slide presentation went through.